So what do? We try to find out who all can develop cardiac disease and try to prevent it. So we try to predict it by having various risk factors, like for example diabetes, lipids, hypertension, thrombotic disorders, behavioral, inflammatory, demography and genetic. But the prediction is that in spite of all this, by 2020, almost 40% of deaths will be CV deaths, and that will be twice that of cancer. In short, whatever we are using to predict is not of as much use as we would want it to be. So what do? The issue is that in spite of a lot of innovations, lot of inventions, lot of discoveries and lot of equipments, the end result of a cardiac patient is always the same. You know, a patient, once he enters into the triangle of cardiac problem, it is one side angle is medical management, angioplasty, CABG. And he keeps shuttling between all three until the inevitable happens. And this is very costly also. Now what do? We then think, okay, the moment patient has a symptom, we will treat him. But the problem is that the first symptom is often hard to deal with. And the first symptom is sudden death. As you can see here, almost 62% of men and 46% of females, myocardial infarction or death was the initial presentation of CAD. So in spite of all your risk factor assessment, such a large number of people may land up either with an MI when a damage has been done, or they may die. So what do? Then we now try to investigate a normal person. We do his lipid profile, we do his risk marking, we do his TMT. Again, these are all can have their fallacies, they can be false negative also. Should we do angiography in all the patients? Okay, you go ahead and do angiography in all the patients, but the paradox is that we would be treating with stents the patients who are having significant stenosis at more than 70%. Unfortunately, the severity of coronary stenosis prior to an MI in almost 68% patients was less than 50%. You all know and agree that it is the regions which are less than 50% which can lead to the damage and infarctions, and not the regions which are 70% and generally have calcium and then are thickened fibrous cap and generally have good collaterals. So this is also not a solution. Then we have a lot of scores. Like you all know, the Framingham is the most common and very well-known score, but we have a lot of scores. But again, you can have a lot of risk factors. The result is that the prevalence of conventional risk factors in patients with coronary heart disease, either one factor or no factor, is almost 62.4%. So many of your patients, more than 50% of your patients, will actually have only one or no risk factor. So again, there are fallacies in our risk factor assessment. It's not a complete issue. So probably risk factor assessment may not be an adequate indicator. Now this is borne by the fact that our prime target, which has been LDL for a long time, is also of not much use. 77% of cardiovascular events occurred in patients with less than 160 LDL. And 46%, almost 50% of cardiovascular events occurred even though the LDL was less than 130 milligram. So your LDL target also is not able to identify the patients at risk. Therefore, we need more predictive factors, and as you all know, we have a lot of factors now. We have the total cholesterol minus the HDL, the non-LDL fragments, the lipoprotein A, etc., etc. Now the issue is why the role of inflammation is now being highlighted, because coronary artery disease practically means atherosclerosis, and atherosclerosis represents a series of highly specific cellular and molecular responses that can best be described in aggregate as an inflammatory disease. So whether you have fatty streak, intermediate lesion, remodeling, necrosis, whatever, ultimately it is an inflammation, and finally one day you have rupture of the cap, and then you lead to a complete thrombosis and occlusion of the artery, and you end up with an MI. Now this is just to show that there are a lot of things common with atherosclerosis, which are also present in cirrhosis, rheumatoid arthritis, glomerulosclerosis, pulmonary fibrosis, basically just to show that these are the chronic inflammatory disorders, and there are many things in common with these disorders and atherosclerosis, suggesting that atherosclerosis also is basically a chronic inflammatory disorder. You take metabolic syndrome, you take obesity, you take diabetes mellitus, ultimately oxidative stress, inflammatory factors, interleukin 1, 6, they are everywhere, And by and large, all these are now related to inflammatory disorders, and they are supposed to be chronic inflammatory disorder, but the inflammation has gone beyond what is normal and what is required and what is physiological. And this was borne out with when the HSCRP, the high sensitivity C-reactive protein, it was discovered, or you can say it was found out by a trial, that across different levels of CRP, the risk is different. So if the patient has a CRP of less than 1 versus a CRP of more than 3, the risk of patients having an HSCRP more than 3 for coronary artery disease is much more compared to the 1 less than 1.0. And even if you keep the LDL values same, for example, the group less than 130, 130 to 160 and more than 160, across different groups of LDL levels, CRP level will influence additionally as to the chances of patient developing an event. Again, the predictive value of total cholesterol is to LDL ratio in determining the first myocardial infarction is affected by the HSCRP also. So it adds to the predictive value. So it started with whether we should measure CRP at all or not. We should measure it in primary prevention, whether entire population should be screened or not. Then we went on to measure CRP in apparently healthy elderly people to identify cardiovascular risk. And then we use CRP for stratifying the high-risk patients for atherosclerotic cardiovascular disease. So the importance of CRP has increased over a period of time. And this has been contributed to by these various trials. I will not go into the details of these trials, but basically the CARE, the AF SCAPS and the WASCOPS, these trials showed there was some association of high sensitive CRP with myocardial infarction or with cardiac events. Patients who had cardiac events had higher level of these. Patients who fared badly had higher levels of HSCRP. Patients who had similar levels of cholesterol, LDL cholesterol, but higher levels of HSCRP did worse as compared to the patients who had low HSCRP. Arbiter, Miracle and the PRINCE trials. The importance of these trials is that they established that beyond controlling the LDL, statins also exert an effect by their anti-inflammatory activity. So these trials clearly showed that statins had two mechanisms of action at least. One was lowering the LDL and second was anti-inflammatory action. Now just to tell briefly as to how the inflammation goes over, this is the basic we all must be remembering. That basically it's an activated monocyte along with an oxidized LDL. That is the one which creates everything and all kinds of problems. So we have a macrophage activation, macrophage 1, macrophage 2 we have. 2 is more protective, macrophage 1 is the one which is destructive. And it also produces the nuclear factor, which we will see are the main culprits later on. So we have a nuclear factor pathway and we have a kynurenine 9 pathway. So what happens is inflammatory mediators are produced, CRP, CD40, TNF-alpha, interleukin 1 and interleukin 6. Platelets are already there. We have adhesive molecules like VCAM and ICAM. And with the combination of all this, we get platelet aggregation. So what drugs do we have to affect all these factors? We already have drugs which are affecting this. The prime amongst them is the anti-inflammatory action of statin, as you can see on the right upper corner. Then we have the PPAR agonist, thiazolidine and diones. Then we have antiplatelet agent, aspirin. And then we have a TNF inhibitor. And what about the newer factors? We also have some novel factors, which is one is 3-HAA anti-inflammatory metabolite, and also a nuclear factor that is anti-inflammatory, that is curcumin. So where do we stand today as far as inflammation is concerned? We have statins for the HSCRP and apoproteins, we have ACE inhibitors, we have antiplatelets like aspirin, we have PPAR, gamma agonist, we have TNF inhibitor and CRP, IL-6 and methotrexate. And we have got novel targets, that is the 3-HAA anti-inflammatory metabolites and nuclear factor anti-inflammatory, for example, curcumin. Now this is a friendly pathway. Kynurenine is a very friendly pathway. It is basically an anti-inflammatory pathway. So it helps in the sense that it curbs inflammation, does not let it go beyond a level. Now this is the reaction, you can all go through it, you can see this on the screen. Biochemistry is anyway not a forte of mine nor a liking of mine, but basically tryptophan is ultimately converted into 3-hydroxy anthranilic acid, and the point of importance is that it is converted and it ultimately gets the levels of nicotinamide adenine dinucleotide to increase. Now this, as I said earlier, is a friendly pathway. It is practically anti-inflammatory, and this would curb the inflammation. So we have one novel method is that either we go and increase the level of 3-HAJ, because as you can see in macrophages, it can inhibit the activation of nuclear factor, activity of inducible nitric oxide synthase, antigen independent cytokine. It also plays an important role in immunoregulation. As you can see here, it has effect on lipid metabolism related genes in a favorable manner. It has been shown to decrease plasma cholesterol and triglyceride levels, decrease the VLDL level, increase the HDL level, and it significantly decreases plasma lipids by 1/3 to 2/3 levels. Also, it has an effect on inflammation, as I said earlier. It significantly reduces infiltration of CD4 T cells in atherosclerotic lesions. It significantly reduces inflammation, and that is one of the major reasons why the atherosclerotic plaques they rupture. And it causes 80% reduction in the atherosclerotic lesions. This is in the surface area of the lesion. By stenosis grading, by 30 to 40% reduction has been shown. So these are by and large mainly in animal studies. So summarizing, it's an intermediate product of kynurenine pathway. It has clinically significant benefits in that it's a powerful inhibitor of atherosclerotic lesions, beneficial effects on lipid metabolism with reduced VLDL, chylomicron and increased HDL levels, and it significantly reduces vascular inflammation. So this is one point where this pathway, if you can promote this pathway, we may be able to get beneficial effects. Now comes the other pathway, which is not the good pathway. This is the pathway that we want to inhibit. Because what happens here is the nuclear factor, it is generally inactive, but if it gets active due to inflammatory stimuli, the IKB is dissociated from nuclear factor, which becomes active. Now once it is active, it goes into and translocates into the nucleus. There it causes release of inflammatory mediators, and these are the pro-inflammatory cytokines, as we described earlier, addition molecules like ICAM and BCAM. Now, how do we prevent it? The molecule that Cadila is now developing, and has practically developed, I believe, is curcumin. Now, this is a very, very novel strategy. The strategy here is to prevent the activation of nuclear factor. So, at this first point, it blocks it. Second point of action is prevents the translocation into the nucleus. And third point of action is prevents the release of inflammatory mediators. So if we are able to do all these three, we will be drastically able to reduce the inflammation. And by reducing the inflammation, we are likely to reduce the plaque rupture. Our basic aim is that the plaque should not form if possible. If it forms, at least it should not rupture. So this has got multiple sites of action. So this is a drug I wanted to talk about today, and I think this should hold a very good future. It is a polyphenol responsible for the yellow color of turmeric, a curry spice. Turmeric, I am sure you all know, and people of my age or elder would always remember the great Vico turmeric ad that we had in our days. So as traditional Indian and Chinese medicine, it has been used to treat a variety of diseases. It's anti-inflammatory, antioxidant, anti-carcinogenic, anti-thrombotic, and cardiovascular protective effects have been demonstrated. It has an anti-inflammatory role in cardiovascular diseases, decrease in the C-reactive protein, and that is a marker of inflammation, decreased MI associated with CABG. Now this is a very small study, but it is a study in human beings. It is a study of 121 patients of CABG, and it has shown to decrease the incidence of MI post-CABG, and that is very important. It reduces serum cholesterol, again a good thing, improves right ventricular diastolic function, prevents progression of diabetic nephropathy, and decreases fasting blood glucose, HbA1c, and insulin resistance index. Insulin resistance is basically one of the major factors contributing towards metabolic syndrome. So what about the heart? This drug And regarding adriamycin-induced cardiovascular toxicity, adriamycin is a wonderful anti-cancer drug, but you all know that giving adriamycin can lead to tachycardia, can lead to SCT changes, ventricular remodeling, ventricular failure. And this drug, by reducing the oxidative stress, it reduces the incidence of all this. This has been shown in animal studies, mice especially, and they have given a dose of 200 mg per kg per day. Now regarding diabetic cardiovascular complications, they are reduced because of antioxidant effect and reduces the NO oxidation. Nitrous oxide, as you all know, it is a good chemical and this is protective. So if you can reduce its oxidation and you can increase the amount of nitrous oxide in the body, it is likely to help. As far as the membrane function is concerned, it has been shown to have a membrane stabilizing effect. By this, what happens is that the amount of infarction is limited. The area which is dying or the area which is dead is limited, and therefore long term your myocardial function is preserved, and it gives you time to do an angioplasty and preserve the left ventricular function. Regarding cardiac hypertrophy, it is inhibitor of P300-HAT, and this is the compound which is supposed to be responsible for the hypertrophy of the heart muscles. So it is effective in cardiac hypertrophy also. Because of its anti-proliferative effect, by inducing HO1 expression, it actually can decrease the angiogenesis, it can decrease the atherosclerosis progression, it can decrease the stenting or in-stenting restenosis. And the calcium hemostasis is maintained with the help of inhibiting ATPase activity of calcium ATPase. This is important because in routine and as well as in post-MI patients, calcium hemostasis is important. And the disruption of that can lead to various kinds of arrhythmias, which can be life-threatening. So by stabilizing this, arrhythmias are prevented. Now, some studies in humans, very small studies have been done, and therefore I say you may require a large cohort and you may require a long-term study of large number of patients. But whatever studies have been done in a small number of patients have shown clearly that there is a 33% decrease in the serum lipid peroxidases, 29% increase in serum HDL, that is very important, nearly 12% decrease in total serum cholesterol. This is only 10 healthy volunteers, number is small, but then it's a novel idea and an innovative thing. And this if done over a large period of time, over a large number of patients, I'm sure would benefit results. And on the vascular smooth muscle proliferation, as I said earlier, it can have a role in prevention of atherosclerotic disease and vascular restenosis. The effects have been extensively investigated in the treatment of cancer and anti-inflammatory diseases. Well tolerated in doses as high as 12 grams per day. Most important, low toxicity and low cost, and potential role in the protection against many cardiovascular disorders. Now there is a difference between turmeric, raw turmeric and cumin, because only 0.3% to 5.4% of raw turmeric can be converted is basically curcumin. So you need a highly bioavailable salt, and the dose is 50 milligrams BD for 7 days and can be increased to 200 mg per day after 7 days. Maximum is 400 milligrams per day. This is when you give a highly bioavailable form. So if you give it as a form of turmeric, then you have to give it a lot of grams, and that may not be very practical. So just briefly regarding other targets, we have, as you can see, phase 2 studies, phase 3 studies, and we have a lot of targets which can in the future lead to suppression of inflammation. So other promising therapies are cyclosporine, colchicine, methotrexate. Methotrexate being an anti-inflammatory has a very good potential, and low dose methotrexate in ST elevation MI is being studied in the TET-HICE trial. CIRT trial will evaluate low dose methotrexate in patients with high prevalence of subclinical vascular inflammation. Then you have a CANTO study for canakinumab in patients of CAD and persistently elevated CRP. The results I think will be out by about January 2018. And the blockage of other potential targets such as IL-6 receptors, CC2 chemokinin receptor, CD20. So just to conclude, that despite optimal therapy with current drugs and despite risk factor assessment in patients, we still have 1/3 of low risk individuals with 0 or 1 Framingham risk score who have been known to develop coronary artery disease or cardiovascular disease. Tackling inflammation provides the potential to improve cardiovascular outcomes further. So in addition to drugs that we already have, if we have a good inflammatory drug, we may have benefit. In fact, aspirin has been shown, if given in high doses in arthritis, to delay the onset of diabetes mellitus. Again proving that inflammation is the root cause of metabolic syndrome and the main culprit. Some molecules targeting inflammation are being developed to provide unique additions to cardiovascular armamentarium. Well, we can only go on doing is, we can keep trying to postpone the inevitable by creating as many hurdles as we can. And the attitude should be that let there be a constant fight between yum and hum. And as I said, the attitude has to be कि हम तुम्हें जीने नहीं देंगे और हम तुम्हें मरने नहीं देंगे. Let's hope. We don't know what the future holds in store for us. Thank you for your patient listening.